Okay, so Dr. Owal, you have 10 minutes for a presentation. You have the floor. Can go ahead.
Okay, good morning, my teachers. Good morning, other participants. I'm going to present question 3A of West Africa, April 2024. Wow. Okay. The question says, a scenario of a 45-year-old man with recurrent dyspepsia for many years, not responsive to PPIs. He had H. pylori eradication with triple and quadruple therapy, but his symptoms still persist. He has gastroscopy, which showed multiple ulcers in the gastric antrum, duodenal bulb, and upper half of the second part of the duodenum. No gastric tumor was seen. The questions were, what is the most likely diagnosis? What is the pathophysiologic basis of this patient's symptoms? List 2 organs that can be affected by this condition. List investigations to be carried out for diagnosis apart from gastroscopy, and list 3 treatment modalities. So the first question, what is the most likely diagnosis? The diagnosis is zollinger Ellison syndrome. What is the pathophysiologic basis of the symptoms? The problem all starts by the non-beta islet cell gastrin secreting tumor that is usually found in the pancreas and other parts. And this results in hypergastrinemia, which also results in hypertrophy of the gastric mucosal cells and result in increase in the number of gastric parietal cells with associated increase maximal acid output. Also in itself, gastrin stimulates acid excretion, which leads to increased basal acid excretion, and the large quantity of the acid so produced leads to gastrointestinal mucosal ulceration. Okay. List 2 organs that can be affected by this condition. The commonest are pancreas and duodenal wall. And the investigations to be carried out for diagnosis include fasting serum gastric level, basal acid output, basal gastric secretory volume, gastric pH, and provocative tests. Also, imaging modalities to localize the tumor include somatostatin receptor scintigraphy and CT scan. Treatment modalities, medical modality, surgical, and chemotherapy. So a little on Zollinger-Ellison syndrome, I'm going to present based on this outline. It's a clinical condition that's characterized by unregulated secretion of gastrin leading to hypersecretion of gastric acid and the resulting manifestations. And it occurs approximately in less than 1% of all patients presenting with duodenal ulcers. It has no racial predilection with a slight male predominance of 1.3:3. The mean age of onset is 43 years. However, patients that have associated multiple endocrine neoplasia present earlier, about a decade earlier. And it's caused by non-beta islet cell gastrin secreting tumor, usually in the pancreas and duodenal wall in up to 90% of cases. However, other sites that include virtually most internal viscera and also lymph nodes and ovary can also be primary sites. It's said to be multiple in about 50% of cases, and then also malignant in 50% of cases. This tumor usually is sporadic, but can be a component of multiple endocrine neoplasia type 1 in about 25% of cases. And the etiopathogenesis, like we said before, is the gastrin secreting tumor result in hypergastrinemia, which result in gastric mucosal hypertrophy, increase in the numbers of gastric parietal cells, and then the secretion of the acid leading to mucosal ulceration. It also leads to diarrhea and malabsorption. And the malabsorption is usually multifactorial, being caused by direct mucosal damage by the acid, also inactivation of the pancreatic enzymes, and then precipitation of bile cells. So for diagnosis, a high index of clinical suspicion is needed to make a diagnosis of Zollinger-Ellison syndrome because its signs and symptoms are generally non-specific. Abdominal pain is about to be the commonest manifestation in almost all patients, and this pain is usually in the upper abdomen and mimics that of peptic ulcer disease. Diarrhea is also very common, and also the third most common is heartburn, and this symptom mimics that of gastroesophageal reflux disease. Other symptoms can be vomiting. They can present with GI bleeding and weight loss. In patients in whom they have the Zollinger-Ellison syndrome patient with multiple endocrine neoplasia, a history indicative of nephrolithiasis, hypercalcemia, and also pituitary disorders should be sought in the patient and also in the family. So on physical examination, so the findings may be normal in this patient. However, if they present with gastrointestinal bleeding, they can appear pale. They can be jaundice. If the tumor compresses common bile duct, though this is rare, epigastric tenderness may be there, and then also dental erosions may be noted if symptoms consistent with gastroesophageal reflux disease are present. The presence of hepatomegaly most likely suggests liver metastasis. So there are some situations that raise suspicion to possibility of Zollinger-Ellison syndrome, and this include presence of ulcers beyond the duodenal bulb, usually the second part and beyond, and ulcers that are refractory to standard medical therapy, like in this index patient, and also recurrent ulcers and ulcers that are presenting with frank complications. So all this would raise suspicion of a possible Zollinger-Ellison syndrome. Lab studies to confirm diagnosis. The best screening test is fasting gastrin level. Also, a gastric acid secretory test can be done. This include basal acid output, where more than 15 milliequivalent per hour or more than 5 milliequivalent per hour in patients with prior vagotomy or partial gastrectomy is suggestive of the condition. Basal gastric secretory volume more than 140 mils is also suggestive. And usually gastric pH is less than 2. There are provocative tests, but the most sensitive and specific is a secretin stimulation test, whereby a loading dose of 2 microgram per kg of secretin is given IV after an overnight fast, and then a serial level of the gastrin is measured at different times after injection. So once the diagnosis is established, the tumor must be localized, and the most sensitive imaging modality for detecting primary and metastatic lesion is somatostatin receptor scintigraphy. Also, CT scan can be done. However, the sensitivity for localization of primary tumor is only 50%, and usually it misses smaller tumors that are less than 1 centimeter. The PET scan can also be done, and if no signs of metastasis are seen and the primary is uncertain, endoscopic ultrasonography is also called into play. Treatment, there are 3 modalities: medical care, surgical, and chemotherapy. So the best treatment modality is medical, whereby acid suppression is offered using PPIs, which are the drug of choice. And this could be omeprazole or esomeprazole that are given 40 milligrams twice daily. And the dose
you have 1 minute more.
The dose can be gradually reduced if the symptoms resolve and acid output declines. Other modality is surgical resection in sporadic cases, and then also if there is absent hepatic metastasis. Chemotherapy with a combination of streptozocin with perfluorouracil or doxorubicin is also important. It usually reduces the tumor size and then reduces gastrin level. Complications include perforation. This is a result of ulceration from this tumor. Also bleeding, obstruction, esophageal stricture, and gastric carcinoid, especially in those with MEN1. The 5 and 10-year survival is more than 90% when the tumor is removed surgically versus 43% at 5 years and 25% at 10 years with incomplete tumor removal. These are my references. Thank you very much.
Oh, thank you. Thank you so much for the beautiful presentation and for giving the time. Thank you so, so much. Okay, so now we'll take comments and questions first from the participants. So any comments or questions?
Thank you so much. Mine is just an add-on to what he said. Okay, so 75% of the time it's sporadic, and then 25% of the time it's autoimmune. It is autosomal dominant, especially since it's a neuroendocrine tumor. You know, there's an association with MEN1, that's main type 1. So 75% occurs sporadically, while 25% are actually autosomal dominant. Then, aside PPI, the patient can also benefit from histamine receptor antagonist. So this is said to have, it slows the acid secretion in this patient. So once these drugs are given to this patient, what happens is that the gastric acid level reduces, and then the symptoms actually regress. So, but if giving PPIs and histamine receptor antagonists, they don't suffice, we would now go for surgery, like surgical removal of the tumor. So that will now be the final therapy for the patient. If medical therapy doesn't suffice, surgical therapy would now go in, where we now the peptic ulcer will be excised, and then the tumor will be excised. So that's just an additional thing I have to say. Thank you.
Oh, thank you so much. Please, let's keep the thanks coming on the chat box. Let's keep the thanks coming. Okay, so let me make a comment too. When you wrote the secretin stimulation test, you added G to it. Was that a mistake? No, I think the secretin is without a G. Then what are some differentials? I don't know that I mentioned some differentials. Then I just wanted to add that if you do a gastric pH and it's greater than 3, that excludes gastrinoma. That's a Ellison syndrome. So I don't know, what are some differentials that you came across for the condition?
Okay, I just mysteriously didn't see the slide. Some of the differentials are peptic ulcer disease, gastroesophageal reflux disease, gastric tumors or gastric cancers, also chronic pancreatitis, and hypercalcemia.
Well, thank you so much. Did you have any slides on the complications?
Yes, I do, but it is missing here, but I'm going to add it to the presentation.
All right, thank you so much. Okay, but can you just mention like 1 or 2 of them?
Sorry?
I mean, like the complications. Can you mention a few of them?
Okay, I have it, complication. I have it on the slide.
Okay, it's okay. Okay, so so on the chat box, it's thank you so much for your presentation. Well done, Chief Awad from Dr. Becky. Dr. Usman says thanks for the presentation. So a lot of thanks for the beautiful presentation. So I don't know if there are any more comments or questions. Okay, I can't see any hands up.
All right, sorry, I have something to say. Good morning. Good morning, our chiefs and all the participants. Thank you very much. Just a little add. Thank you, presenter, for a wonderful presentation. You almost said everything. As part of the clinical features, I don't know if you mentioned steatorrhea, because you mentioned that this cancer can actually cause obstruction of the bile duct, and bile cannot be secreted and all of that. So it can cause bile acid malabsorption, which can lead to steatorrhea as well, and malnutrition as well. Then it actually spreads to the liver and to the lymph nodes. And the fasting gastrin level is usually done on 3 occasions. So if you have a level that is greater than 1,000 picogram per mil, then it's diagnostic of zollinger Ellison syndrome. And I don't know if you also mentioned increased level of chromographine A, which is a marker of MENS1 as well. At least I would tell you that you're dealing with a neuroendocrine tumor as part of it. Otherwise, it's a very beautiful presentation. and it can come out in different ways. Usually it affects the duodenum more. Like most of the multiple ulcers are usually in D2, but it can just come as D1, which is also correct because it affects the pancreas, the stomach, and the duodenum. These are the three parts it affects, and it can spread to the lymph nodes and to the liver. Very important. Thank you very much, too. Very beautiful presentation.
Oh, thank you so much, Ma. Okay,
Thank
so
you,
if there are any other comments or questions, I'll hand over to teachers. Ma Christabel, I don't know if our teachers have any comments before we go on to the next.
And Dr. Ekele, quickly, the presenter did wonderfully well. It was what was a wonderful, concise. He kept to time. It was lucid and he answered almost all the questions. Did so well. And as usual, I always appreciate those asking questions and those making comments. Kalamama, thank you. It's like you want to take over from that. You're going to be our chief speaker for this session. Thank you so much. Please keep it coming. Just encourage you. Please keep it coming. Keep talking. We always say it's a talking exam. And Dr. Faith, indeed, we have missed you. Dr. Faith was one of our assistant rep, and she was wonderful. It's nice to have you back and active again. So thank you, everyone.
Thank you.
Okay, thank you so much, Ma. Thank you, Ma. Thank you, Dr. Owal, for the beautiful presentation. Thank you, Ma Faith. Okay, so we'll go on to the next presentation. Dr. Adeyemo Adedapo. He will take in question 3B. Chief, you can share your slide.
Okay, all right. Thank you.
Okay, so you have 10 minutes for the presentation.
Sorry, can I be heard?
I can hear you. I can hear you.
Okay, thank you. All right, thank you. Good morning. Good morning, my teachers. Good morning, my colleagues. I'm Dr. Adeyemo. I'm going to be taking the question 3B. So the question is as thus: a 68-year-old woman with history of cigarette smoking of 40 years and recent weight loss of 5 kg presented with rashes on the hands as shown in the picture below. I'm sure we all have the pictures. He also has difficulty standing from a sitting position. His serum creatine kinase level was 1,800 international units per liter. Questions: A, what is the most likely diagnosis? B, what is the cause of his difficulty in standing? C, what would be the most appropriate next step to making a diagnosis? Option A, to do a CT scan of the chest, abdomen, and pelvis. B, nerve conduction study. And C, study of the thymus. G, electromyography. And then the last question, what must you do to ensure a good outcome? Now, the answers. For the first one, the answer is dermatomyositis. Most likely a paraneoplastic type of dermatomyositis. Other different types of dermatomyositis. Then for the second one, proximal myopathy is most likely caused.
Sorry, Dr.
Hello?
Using two devices. We should mute the other one.
No, I'm using only one device. I'm not using two devices. I'm using only my phone.
Okay, go ahead. All
right, then the second answer is proximal myopathy. That's responsible for the inability to stand because of the weakness of the proximal group of muscles in the pelvic girdle as well as in the thigh. Then also, what is the next most important thing to do? The next most important thing to do is actually to do a screening, of different types of malignancies. So the best option here is option A, to do a CT scan of the chest and the abdomen as well as pelvis. And then the last thing is to what must we do to ensuring a better outcome, a favorable outcome before we commence treatment. So usually before we commence treatment, we are supposed to screen the patient for systemic malignancies. And then we should also do auto-antibody markers, because dermatomyositis is a form of inflammatory myopathy, and it could be either related to malignancy, sometimes it could be autoimmune mediated, or be associated with some connective tissue disorders. And sometimes it could be idiopathic. So, because of that, in order to achieve a favorable outcome, we must understand or get the etiology first, so that we direct our treatment to the underlying etiology. So, if we are able to get the etiology and direct our treatment to the underlying etiology, it will make the treatment outcome to be more favorable. So, I have just a few slides on inflammatory myopathies, and then turn down to the dermatomyositis. The inflammatory myopathies, basically, they are characterized by four major manifestations. We have chronic inflammation of the striatal muscles with proximal muscle weakness, known as proximal myopathy, as well as elevated enzymes with an abnormal EMG. There are different types of the inflammatory myopathies. We have the poliomyositis, dermatomyositis, inclusion body myositis, and amyotrophic dermatomyositis. It is worthy to know that when you now have cutaneous manifestations, then we say the patient has dermatomyositis. And patient can also have dermatomyositis without the muscle involvement. This is known as amyopathic dermatomyositis, such that the patient only has cutaneous manifestations. There are some additional disorders that can be associated with dermatomyositis. Just like I said, sometimes it could be associated with some connective tissue disorder, and it could be autoimmune mediated, and sometimes it could be associated with malignancies. These malignancies are called U-shaped malignancy. That is, if we take it from the breast to the lung, the pancreas, to colon, to ovary, then again up like that to the breast and the lung. So the malignancy is usually like a curve of U-shaped. The incidence of inflammatory myopathy is about 2 to 10 new cases per million, with the highest incidence usually found in Western Australia, and it's more common and in female than in male, with a female to male ratio of about 2:1. There are some environmental factors that could actually affect the development of the condition. This includes the presence of infections, such as infection by Kawasaki, infection by HIV, among others. There are some also genetic factors that will also increase the susceptibility of an individual developing them. This include the human leukocyte antigen, DRA, LA, DRB1. Also, it has also been demonstrated in monozygotic twins as well. The main clinical features that are found include the insidious and progressive painless symmetrical muscle weakness, and then sometimes the acute onsets with pain and weakness usually demonstrated in children. And apart from that, for a patient that has inflammatory myopathies, generally can also present with some other clinical manifestations, such as edema of the eyelids, hoarseness of the voice. All these clinical manifestations actually depend on the underlying etiology. It is the underlying etiology that will determine what are the other extra systemic manifestation that will be presented by the patient. But usually, a patient that has dermatomyositis will present with a cutaneous manifestation apart from the proximal muscle weakness. And we're going to be looking at some of these cutaneous manifestations. This includes, one, the presence of guttural papules. These are some popular rashes that are found over the knuckles. Some of them are usually purplish in color. And then we also have the electro rash, usually found over the eyelids. And then we also have the sensitivity, increased cutaneous sensitivity, as well as facial erythema. Other ones we can also find include nail erythema, as a result of dilated loops of capillary. And then also we can also have Shaw sign. This Shaw sign is characterized by macular rashes. They are usually found on the chest as well as on the back as well. We also have the involvement of the joints, polyarthralgia, polyarthritis, and others. So you can also have respiratory involvement too. And then the heart can also be involved. Patient can develop some arrhythmias, they can go into failure, pericardial effusion. GIT can also be involved with aspiration as well as difficulty in swallowing. Kidneys involvement is also can also be seen as well. Patient can have acute tubular necrosis as well as glomerulonephritis, especially the membranous type of glomerulonephritis. These are in differential diagnosis that can mimic a patient that has inflammatory myopathies. Some of the common malignancies include ovarian cancer, melanoma, genitourinary, lung cancer, as seen in our index patients. We also have some investigation that can be done in a patient that has inflammatory myopathies. This investigation include the liver enzymes as well as the skeletal muscle enzymes, especially creatine kinase, adolase, and other and lactate dehydrogenase as well. EMG can be done. When EMG is done, EMG will show us the characteristic fibrillating potentials, and then the confirmatory diagnosis is confirmatory test is to do biopsy of the muscle. This will also help us to exclude some other mimicking conditions. And then it's very important that we screen for malignancies. This must be done before we commence patient on treatment. Serology, you can also ask for some antibodies, including anti-nuclear antibody, anti-Jo1, as well as anti-MI2 antibodies. It's very important to state that some of these antibodies are actually not that highly sensitive. Therefore, the negativity of the antibodies does not rule out the presence of inflammatory myopathy. We can also screen the patient for anti-RNP antibodies for the possibility of means connective tissue disorder. So some of the cancer. Okay. So we also have a diagnostic criteria that takes into consideration the earlier stated clinical features. Treatment, basically, the treatment is appropriate evaluation and determination of the etiology is very important in treatment, and is usually targeted at looking at the underlying cause. And when the underlying cause is treated significantly, there is improvement of the symptoms. The underlying cancer treatment results in significant improvement of the myopathy. And then usually, basically, we have the treatment of the muscle weakness as well as treatment of the cutaneous manifestation in dermatomyositis. For the muscle weakness, we start the patient on high dose steroids. Usually, we give the patients about 0.5 to 0.2 milligram per kg per day of steroid, but usually an average of 1 milligram per kg per steroids. Patients should be covered with PPIs as well as with anti-emetic to prevent the possibility of the patient developing invasive strongyloidiasis. Immunosuppressants that are usually used include azathioprine, methotrexate, cyclosporine, mycophenolate, as well as cyclophosphamide. These are usually especially important for refractory cases of dermatomyositis, and then we can also make use of biologics as well. It is very important to also make use of physiotherapy, to prevent the contracture, so that when the patient is on admission, we exercise the muscle to prevent the possibility of patient developing contractures. For the treatment of the skin disease, patients should try as much as possible to avoid use of photoprotective sunscreen as well. Then basically we have two important medications that are used in skin manifestation in dermatomyositis. This include hydroxychloroquine as well as calcineurin inhibitors like tacrolimus. But if the patient is resistant to these two medications, it is advised that we still use methotrexate for the patient's management. Thank you for listening to me.
Oh, thank you so much for the very lucid and concise presentation. It was beautiful.
Thank you.
Okay, so now welcome comments, questions from the participants first. I don't know if we have any comments or questions. And let's also drop our thanks on the chat box to Dr. Adeyemo. Okay, so while we're waiting, I just wanted to add to the clinical features. I don't know that you mentioned Gauthron's papule, Gauthron's sign.
Yes, I mentioned Gauthron's papule, short sign. We have the mechanic hand. We have the electroprash. We have the nail erythema, dilated loops of capillaries. We have quite a number of the cutaneous manifestations.
Okay, there's Holter sign too. And then sometimes, I think I saw somewhere Holter sign when they have redness over the buttocks and the lateral thigh. Then sometimes they could have Raynaud phenomenon.
Yes, I mentioned Raynaud phenomenon too. Okay. And it's also very important to know that electroprash and Gauthron papules are more common and more specific for dermatomyositis than other cutaneous manifestations, especially once there is elevated creatine kinase. Thank you.
Okay, what are some complications? I know you mentioned the joint contracture.
Yes,
I think because of the muscle weakness, I think they also have dysphagia too, with dysphonia.
Yes, I mentioned it under the GIT manifestation. I did mention that the other clinical manifestations are functions of the other etiology. In the GIT, they can present with aspiration pneumonitis, they can present with difficulty in swallowing, dysphagia. In the renal, they can present with acute tubular necrosis, they can present with membranous type of glomerulonephritis. Then in other systems could be affected.
All right, thank you so much. Okay, so let me go to the chat box. Everyone is saying thanks so much for the beautiful presentation. Dr. Momodu Jafar says thanks for the beautiful presentation. How can we differentiate dermatomyositis from polymyositis?
Okay, well, differentiating dermatomyositis from polymyositis, one, in terms of the etiology, usually polymyositis is more associated with autoimmune condition than malignancies. But dermatomyositis is more associated with malignancy than autoimmune condition. Although it's been said that it is about 30 to 35% of cases of dermatomyositis are associated with malignancy, but it's more commonly associated with it. Then in terms of clinical manifestation, we find cutaneous manifestations in dermatomyositis. All the cutaneous manifestations that we have said, with proximal myopathy, is most likely to be a dermatomyositis and not polymyositis. Polymyositis does not present with cutaneous manifestation. Also, if you have the facility to also screen the patient for autoantibodies, you find the presence of anti-Jo1 antibody is much more specific for polymyositis, while anti-MI2 antibodies is more specific for dermatomyositis. And then the findings of elytral rash, Guthrun's purple, Shaw sign, all of that, they bring in more of the dermatomyositis than the polymyositis.
All right, thank you so much. Okay, so Dr. Suri says, thanks. When the photosensitive rash occur in the chest, it's called V sign. Did you mention that?
I didn't mention that,
okay.
But there's also a sign called Shaw sign. The Shaw sign is also characterized by the presence of rashes on the chest and also on the back, although the rash is described as a macular rash present on the chest and also on the back.
Okay. Thank you so much. Then Dr. Olaiton says, please, can you mention the muscle biopsy findings?
Usually the characteristic muscle biopsy are usually we see the striated, usually more of a striated how do I put it now? We find the presence of striated muscles fiber with depletion of the muscle fibers. I don't know if that's okay, but that was what I was able to find, that when we do the muscle biopsy, we find depletion of the striated muscle fibers.
Okay, thank you so much. Maybe a dermatologist in the house will help us out later. Okay. So Dr. Flavi says, thank you so much. Dr. Rita Wakama says, thank you so much for the presentation. Dr. Yahya Mohammed says, thank you for the beautiful presentation. And Dr. Adibokar John says, thank you so much. Okay, so now I'll hand over to our teachers. They have comments and questions, contributions. Dr. Christabel. Hello,
Dr. Ekele, Dr. Yahya hand has been up. I think Success and 2 is also up.
Okay, sorry. Please, Dr. Yahya, go ahead.
Okay, thank you very much, Chief, for the very good presentation. Thank you, the class rep. And regarding the muscle biopsy findings, some of the findings that we see are fiber necrosis of the muscle fibers, and sometimes regeneration in association with an inflammatory cells and infiltrate. And even some lymphocytic infiltrates can be seen from that biopsy findings. However, for us neurology, again, we are more interested in EMG findings, in which this is one of the muscle disease that have characteristic EMG finding. Of note is they used to have spontaneous fibrillation potentials. We have a lot of potentials, but this one, they have spontaneous fibrillation potentials. And again, they have short duration potentials on voluntary contraction of the particular muscles. And they have a characteristic finding that is called salvos of repetitive potentials on mechanical stimulation. These are very interested for neurologists because we deal with so many muscle disease, of which this is one of the one that has a characteristic finding. Thank you. It's a very beautiful one. Thank you very much.
Oh, thank you so much, Chief. Yeah. More success. Please go ahead.
Okay, good morning, senior colleagues and colleagues. I want to sincerely thank the presenter for this amazing presentation. Dr. Adeyemo, thank you so much.
Thank you.
Just an add-on. Dr. Yaya, one of the subspecialties, subspecialty question, this muscle biopsy finding of dermatomyositis came out. Okay, and so one of the options were fascicular atrophy. Okay, so that's what we so you are right. So what we see in them is perivascular fascicular atrophy. And then just to ask you, the presenter, you talked of amyotrophic dermatomyositis. So how do we differentiate that with polymyositis? And then run us through the differential diagnosis, okay, of dermatomyositis. Thank you.
All right, Mark. The differentiating myopathic dermatomyositis. For a patient that has myopathic dermatomyositis, usually they will present with only cutaneous manifestations of dermatomyositis. They will not present with proximal muscle atrophy. So that a patient that presents with the typical cutaneous manifestation, especially the heliotrope and the contrast purple, and we have a high clinical index of suspicion of inflammatory myopathy, and we do important investigations, fix the liver enzymes, the autoimmune or autoantibody, and also muscle biopsy. Autoimmune or autoantibody, not muscle biopsy, autoimmune antibodies, and then we find the characteristic presence of the autoantibodies, and then the heliotrope rash, Guthrun's purple. Then we can actually make a diagnosis of a myopathy, despite the fact that there is no muscle involvement. But so basically, there is no muscle involvement, there is no weakness, there is no inability to stand in a myopathic type of dermatomyositis. But in the classical dermatomyositis that has muscular involvement and cutaneous manifestation, they will have all those muscular involvement. Then in terms of the differentials of dermatomyositis, some of the differentials are including one, polymyositis is one of the differentials. In polymyositis, we are not expected to find the cutaneous manifestations, but the patient will still have the proximal myopathy. Then also, the patient can also have duchenne muscular dystrophy. This is usually found more in children. Usually, they have a characteristic walking pattern like a dog. Characteristic walking pattern, and there is a sign that is usually demonstrated in them. Goa sign. Goa sign is usually positive in patients that have duchenne muscular dystrophy, which is not present in a patient with in children type of dermatomyositis. And then also we don't expect to find a dermatological manifestation in duchenne muscular dystrophy. Then also other possible differential diagnoses include motor neuron disease, especially when we have the involvement of the respiratory muscles as well. Patient can have weakness of the respiratory muscle, difficulty with breathing. So motor neuron disease will also be a differential, especially the amyotrophic lateral sclerosis type of MLD, motor neuron disease. And then we may also have diabetes myopathy too. It's also a differential diagnosis to DM myopathy. And of the patient will be a known diabetic, usually a chronic diabetes who's been diagnosed with diabetes for a long period of time, probably with poor glycemic control. And we'll also be able to find some other chronic complications of DM in the patient as well. These are some of the few differentials.
Yeah, thank you so much. Thank you.
Thank you.
So amyopathic dermatomyositis is also called, it's a subtype of DM. There's dermatomyositis, and then it is also called dermatomyositis, sign myositis. So this is important because they present its only dermatological manifestations, and then it must be present according to the criteria for at least 6 months. I don't know for the differential diagnosis, I don't know if you called SLE. It's also a very important differential. Thank you so much. You did very well. Thank you.
Thank you.
Oh, thank you so much, Ma. Thank you, Dr. Yahya. Okay.
Thank you. So the speaker, Dr. Adeyomo, thank you so much. Your presentation was clear, lucid. You speak like a fellow consultant already. I love your confidence, and you seem to have in-depth knowledge of the topic, which is wonderful. Show that you didn't just brush through it, but you took your time to really understand it. This is something we encourage in this our platform. So I really want to chip that in. Then just in case in an exam you are asked, the perifascicular atrophy is actually more specific for DM. You see other changes, inflammatory changes, regenerative and degenerative changes in the muscle, but perifascicular atrophy is more specific for DM. So thank you everyone that contributed. Our dear, beautiful, energetic facilitator, Dr. Success, Dr. Yahaya, and Dr. Kalamama, and everyone that contributed. We appreciate you. And somebody asked a question. I think I'll let the presenter handle that because he mentioned it already. He asked why CT scan before treatment. Dr. Kelly, I don't know if you saw it.
Yes, I said it. CT scan, we must screen the patient for systemic malignancies because approximately 30 to 35% of cases of dermatomyositis are associated with malignancy. That was where I mentioned the U-shaped malignancy. That was what I coded the malignancies when I was going for part 1. So once you know the U-shaped malignancies, patients should be screened for all of those malignancies. We may be able to find evidence of any of the malignancies. And also, sometimes the malignancies might not even manifest. The clinical manifestation of malignancy might not even manifest before we have some of the manifestation of the inflammatory myopathies associated with the malignancy. So it's very important that we screen the patient. We do CT scan of the abdomen, of the chest, of the pelvis, even the bone MRI. Just rule out any form of malignancies.
Thank you so much. Because if there's malignancy and you are focusing on the DM, the patient will not do well. But it's from malignancy and you treat the malignancy, the DM symptoms will also disappear. So that's why your focus is on treating, managing the malignancy. Thank you so much, presenter. We appreciate you, really. We do. Let's take over to you. I don't know if
thank you so much.
Have any comments? Chief Cookie, Chief Chichi.
Good morning, Dr. Christopher.
Good morning, sir.
Yeah, morning. I just wanted to chip in a little thing. The presenter had done so well. But when he was talking about the immunosuppressives, he said resistance. You don't develop resistance against immunosuppressives. Rather, they can be non-responsive. Patient may be non-responsive or may not respond. There are some examiners that may be a bit finicky about English and using the right term.
Sorry, sir. I meant to say refractory. Refractory.
What?
I meant to say refractory. Sorry. What I said.
That's a better.
Yes. Thank you, sir.
All right. Well done.
Thank you.
Oh, thank you so much, sir. Okay, Chief, you cannot share your screen.
Okay, I'm trying to do that.
Okay, so
let me log out.
I think we can take the next presenter. That'll be Dr. Florence Briggs. Hello, Dr. Florence. Hello. Are you there?
Okay, I'm with you. I'm with you. I was trying to unmute.
Okay. Okay, please share your screen.
Okay. Okay, so can you see my screen now?
Yeah, I can see
Can
it.
you see my screen now?
Yes.
Okay.
Yes.
Okay, so good morning, senior colleagues and colleagues. Today I'll be taking practice question 4A, April 2024. Okay, so a 37-year-old IT professional has complaints of 2 days history of headache and fever with temperature measured at home, 39.2 degrees centigrade. He has been seeing the ENT surgeons for recurrent ear infection. He drinks alcohol up to 40 units per week. He lives with his wife and 2 children who are currently okay. The headache is worsened by noise and light. On presentation, he has a fever of 38.8 degrees centigrade and neck stiffness. However, he's conscious and able to obey commands. He's being nursed in a quiet and dark room. Fundoscopy was normal. He had a lumbar puncture and CSF results were as follows. CSF result was 1.2 millimole per liter, which was reduced. CSF WBC was markedly elevated with predominant neutrophilia. His random blood glucose was 5.8 millimole per liter at the time of sample collection. Number 1, what is the diagnosis? The diagnosis is actually acute bacterial meningitis, evidence being that the patient gave a history of 2 days, making it acute. And then the new criteria says that if a patient comes down with headache, fever, neck stiffness, and altered consciousness, 2 out of these, if it's present, the patient meets the criteria for having meningitis. So out of this patient had headache, fever, and neck stiffness, alongside with photophobia and phonophobia. So for bacterial meningitis, the patient actually had hypoglycemia, which means that the glucose CSF was reduced, and also comparing it with the serum glucose, it was less than 60%. The CSF glucose was less than 60% of the serum glucose, which is in keeping with bacterial meningitis alongside with neutrophilia and the CSF. So the potential site of the colonization was the ear, nose, and throat due to recurrent ear infection. So what 2 clinical signs will be useful to elicit these patients? We have the Koenig sign and then we have the Brzezinski sign. So for the Koenig sign, if you look at the patient, the hip is being flexed at 90 degrees, and then trying to extend the knee joint, there's difficulty in extending the knee joint due to stiffening of the hamstring muscles, and also when trying to extend the knee joint, what happens is that they present with pain at the spinal area, because what happens is that you're trying to stretch the spinal cord against the inflamed meninges, so they present with pain also, and that's the Koenig sign. And Brzezinski sign, on flexion of the neck, the knee and the hip joints are being flexed, so that's the Brzezinski sign. Okay, so what is the most likely causative organism? The most likely causative organism is Streptococcus pneumoniae. Why? Being that the common causative organism between the age range of 2 to 50 is Streptococcus pneumoniae, although we still have Haemophilus influenza and Neisseria meningitis, but Streptococcus pneumoniae stood out because we can also find it in chronic alcoholics, and as well with patients who come down with otitis media, which this patient had. So out of the 3 common causative organisms, that Haemophilus influenza and Neisseria meningitis, Streptococcus pneumoniae actually stood out because it is found in 3 of these conditions listed below. Okay, so which investigation or procedures will you do in his management? Because of the recurrent ear infection, I want to do an ear swab, microscopic culture and sensitivity, full blood count, ESRO, of which we can have elevated WBC, C-reactive protein, and procalcitonin, which can show the patient has an acute bacterial infection. I also want to do a liver function test, abdominal ultrasound scan, serum electrolyurea creatinine, to look at the status of the kidneys and also the liver of this patient who is a chronic alcoholic. And the brain MRI or brain CT scan will be done to rule out the brain, to rule out complications that could arise from meningitis. How will you manage this patient up to discharge? It's actually a multidisciplinary measure that involves a neurologist, ear, nose, and throat doctor, a neuropsychiatrist, nurses, and then also a gastroenterologist. So I will continue to nurse this patient in the quiet and dark corner because this patient is photophobic and phonophobic. I optimize the airway, breathing, and then circulation. Give antipyretic because the patient is pyretic. And then also IV antibiotics for at least 2 weeks, which would comprise of IV ceftriaxone 2 milligrams 12 hourly, and then IV vancomycin 15 milligrams per kg 8 hourly, which should be doing slowly to prevent red man syndrome in these patients. Then steroid therapy has been said to be controversial, but what we will give it as an adjunct IV dexamethasone 0.15 milligram per kg 6 hourly for 2 to 4 days. Why? Because this is said to interrupt the cytokine-mediated neurotoxin effect of bacteriolitis, which actually occurs maximally at the first days of antibiotic use. So I've also given tablets thiamine 250 milligrams daily for the first 5 days, then taper down to 10 milligrams daily because this patient is a chronic alcoholic who may be deficient in vitamin B1. On discharge, I will counsel this patient on the need for meningitis preventive vaccines like pneumococcal vaccine, Haemophilus influenza vaccine, as well as meningococcal vaccine. I also counsel this patient on moderation of alcohol intake. The need for a neuropsychiatrist is actually needed because meningitis has been said to cause mental strain due to the severe illness, and also they come down with personality changes following meningitis. So a neuropsychiatrist will also do so well in the management of this patient. So now I'll just talk a little about acute bacterial meningitis. So first and foremost, meningitis is inflammation of the leptomeninges, which has got to do with the subarachnoid matter and the dura matter. So what happens is that it also includes the subarachnoid space, leading to constellation of symptoms and signs with presence of inflammatory cells in the cerebrospinal fluid. Acute meningitis is just defined as the onset of symptoms of meningeal infections over courses of hours to several days. Now, this is actually showing the African meningitic belt, which actually spans through Senegal to Ethiopia. So clinical features, as previously mentioned in the body of the question. So pathophysiology, so there's a colonization of this infectious agent in the host. So the potential sites of the colonization of the infection includes the skin, the nasopharynx, the respiratory tract, the gastrointestinal tract, and also the genitourinary tract. So what happens is that the organism invades the submucosa at these potential sites by circumventing the host defense. So there's now what bacteria gain access into the CNS via hematogenous spread, retrograde neuronal pathway via the olfactory and the peripheral nerves, and then also direct contagious spread. So what happens is that the blood-brain barrier is then breached in this patient, and then the organisms become isolated from the immune system and then spread to other sites. So this replicating bacteria then induces inflammatory cells, leading to cytokine-induced disruption in the membrane transport and then increasing the vascular permeability, perpetuating the infectious process called the bacterial meningitis. This is said to lead to changes in the CSF cell counts, pH, the lactate protein, and then glucose in the CSF. So these are actually common bacterial pathogens on the basis of age and predisposing factor. So I will just go straight to the extremes of age, where we see Listeria monocytogenes dominating, as well as other bacterial pathogens. So now this is also telling us about the causative organisms and then the underlying medical conditions. So when we have a patient with paranasal sinusitis or otitis media, we should be thinking of maybe the infective organism is Haemophilus influenza, pneumococcal Streptococcus pneumoniae, or if we have a patient following is skull fracture and then suddenly develops symptoms and signs of meningitis, we should be thinking of a streptococcal infection as well as others mentioned here. So in making the diagnosis, I've actually referred previously to the outlined the body of the question and the answers in making the diagnosis for this patient. So now, what are the common CSF findings in differentiating bacteria from viral and also from fungal? So we noticed that the opening pressure is actually increased in bacterial meningitis. The cell count of WBC is increased, protein is also increased, and then the glucose is reduced. The same thing occurs with the fungal and TB meningitis. But when it gets to the viral aspect, the opening pressure is either increased or normal. The WBC is increased. Okay, thank you. The WBC is increased, and then the protein is increased, and then what happens is that the glucose is normal in this patient. So complications that can arise include septic shock, hydrocephalus, ataxia, mental motor impairment, focal paralysis, subdural effusions, cortical blindness, and others listed there. So in treatment of acute bacterial meningitis, I've actually mentioned it, but talking about extremes of age because they are infected with Listeria monocytogenes, and penicillin will be rather used to replace the vancomycin in addition with ceftriaxone. So the differential diagnosis include brain abscesses, brain neuroplasms, delirium tremens, because the patient who is a chronic alcoholic probably must have withdrawn from alcoholism, then subdural hematoma, encephalitis. The prognosis is actually better if it's the infective organism is Haemophilus influenza, and then worse with strep pneumoniae. So these are other causes of chronic meningitis, which we have with coccus and then tuberculosis. So the take-home message: bacterial meningitis is a rare but serious inflammation of the meninges caused by various bacteria. It commonly affects extremes of age because of impaired or waning immunity. The incidence, morbidity, and mortality from acute bacterial infection, bacterial meningitis, have decreased significantly as a result of vaccination, better antimicrobial and adjunct therapy. Early identification of the disease and treatment of patients with acute bacterial meningitis is essential. Thank you for listening. These are my references.
Thank you so much for the beautiful, lucid presentation. Okay, so now we'll take comments and questions from the participants first. Chief Florence, sorry, I was logged out. I don't know if there are comments on the chat. Can you help me check? So, okay, so thanks for the presentation. Dr. Adebimpe is saying thanks for the presentation. Other complications are deafness and visual impairments. Thank you so much, Dr. Adebimpe. I don't know if we have more comments. I can't see any hands up. Okay, so Dr. Mark is saying thank you for the beautiful presentation. Dr. Usman is saying thanks. Dr. Tom is saying thanks for the presentation. Dr. Taribi Cornelius is saying thanks for the beautiful presentation. Dr. Momodo is saying thank you so much for the beautiful presentation. So a lot of thanks for the lucid presentation. Okay. I don't know if we have more comments or contributions. Okay, so Dr. Bashir, Dan Sander.
Yes, okay, good morning. Thank you for the very beautiful presentation. It's just a little addition to what the presenter presented. The issue of use of steroids in meningitis. Actually, for children, there are many studies that have shown benefit in using steroids for acute bacterial meningitis before commencing antibiotics. But in adults medicine, actually, that has not been proven. And for the generality of it in ID, actually, the use of steroids for meningitis is not supported, or it's not, there's no evidence to support that. So just an addition to what you said. Thank you very much.
Hello, Chief, I can't hear you. Are you done? Dr. Bashir?
He's done. He's done.
He's done.
Thank you, Bashir. There's a comment from Dr. Success. I don't know if the neurologist can make an attempt, or the presenter can attempt, because the presenter has done well, so I'm sure you want to say something. So you can go ahead.
All right, so from Mass Success, please, can the neurologist in the house tell us how hyponatremia, SIADH, is a complication of meningitis? And then Dr. Momodo is saying any role for vaccination. Okay, Dr. Florence, go ahead.
Okay, for SIADH, when I read it, they just talked about when there's aggressive use of the diuretics in the patient that can predispose to hyponatremia in this patient, and then presents with SIADH in the patient. So that was basically what I saw as SIADH being a complication to meningitis.
Yeah, I don't know if any neurologist in the house wants to add more to that.
Dr. Yahaya, any comment on that?
Let me try.
Yeah,
Hello?
exactly.
Hello. Hello, good morning, everyone.
Go ahead. Go ahead.
Okay, so I think the pathophysiology of SIADH and hyponatremia in meningitis can be explained by the fact that meningitis affect the pia and the arachnoid, and the pituitary gland, which is actually responsible for the secretion of ADH, that helps in the sodium absorption in the kidney, is also affected in meningitis. So I think that's how SIADH occurs. Thank you.
Thank you so much. Okay, there's a comment also on the chat. Any role for vaccination? I think she mentioned it. I think she mentioned
Yeah, there's a
vaccination.
rule. We have three common
Talked about
causative
meningococcal
organisms.
vaccination.
Yeah,
influenza.
meningococcal, Haemophilus influenza,
Okay.
and then also pneumococcal, because these are the commonest causative organisms for meningitis. So the patient can actually be vaccinated against that. Then again, in pandemic, where we have Neisseria meningitidis, his wife and his children are supposed to get prophylactic antibiotics like ciprofloxacin or cephalosporin, because that's highly infectious. So that could be actually contracted via body fluids. But because this is a streptococcal infection, so that's why we are not giving them prophylactic antibiotic like ciprofloxacin as well as cephalosporin. So that is why we didn't give. Otherwise, if it was in an epidemic, they should get the prophylactic antibiotic.
I know it's so bad. Are you done? Okay, my success.
Okay, good morning, senior colleagues and colleagues. Thank you so much, Dr. Florence, for the lucid presentation. Florence, please, can you go to the question again? There's a question that one of the sub questions, to this question. Okay. Okay, so please, what did you say in this number 4? Which investigation or procedure will you do in this patient? Please, what did you say, Dr. Florence? I didn't hear.
Okay, I talked about ES4, dose of infection is coming from there. Then I also thought of doing a full blood count ESRO for this patient, which the patient did not get from onset. Then I also thought of doing procalcitonin. Procalcitonin, when elevated, it actually helps us to clench down our diagnosis of bacterial meningitis. Then I also thought of a brain CT scan. Already the patient, there was no papilledema when they did fundoscopy. So that's why they went ahead to do a lumbar puncture. So that already ruled out that there was no form of raised intracranial pressure. But the reason why it puts in a brain CT scan or brain MRI is to rule out complications that can actually occur, like a brain abscess or other complications that can occur following meningitis. Then also, I talked about doing, this patient is an alcoholic, so I'm actually dealing with the patient holistically. So I talked about doing a liver function test, electral urea creatinine test for this patient, and then abdominal ultrasound scan to look at the state of the kidneys and also the liver of this patient. Then also
okay, so that's fine. Thank you so much.
Yeah, that was
thank you. That's that, because when we saw the procedure in the exam, we are like, what do they want to say again? So yeah, you are correct. Then we can also check the ears. Okay, so we do otoscopy. Now you talked of how do we differentiate between chronic and acute meningitis. So when it's chronic, it's more than 4 weeks. Now for patients, why does this patient not have viral meningitis? Why did you change your diagnosis on bacteria? Or when you see
in viral meningitis, the glucose in the CSF is normal because the virus doesn't feed on the glucose. Okay, clinically, they don't. The neck stiffness is not so marked, as in symptoms in viral meningitis is not as marked as that of bacterial meningitis. So they may not come in this severe form as compared to bacterial meningitis. The neck stiffness may not be this severe. The fever may not be this high because at the point it was 39.2, which was hyperparetic. So the level of the pyrexia would not be this high. The severity of the symptoms will not be this way, and they may not even be photophobic or phonophobic. So I think this patient has the symptoms are very severe as compared to viral meningitis that is kind of mild. Then also the needles of infection is from recurrent ear infection. So it's not so common as bacterial infection. Yeah, so that is why I actually changed my diagnosis to bacteria.
Yeah. So Brodinski, Kenix, neck stiffness, all those will not be there clinically in a patient that has viral meningitis. I just wanted to say finally that I know one of the marks I got in this exam. So for prophylaxis, for patients that are taking care, the caregivers, okay, of patients with meningitis, you want to place them on either ciprofloxacin or rifampicin. So this is one of the things I also said that earned me a mark. So it's important we also say that. Thank you so much for the lucid presentation. You did well. Thank you, Florence.
Thank you. Thank you, Chief.
Thank you so much, Ma. Thank you so much, Ma. Okay, so I'll hand over the class to Dr. Christabel now. Thank you so much. I'll hand over to her.
Thank you. Thank you, Dr. Ekele. That was wonderful. Thank you, Dr. Awa, Dr. Adeyomo, and our dear Dr. Florence. The three of you delivered as expected. Thank you so much, Dr. Kalamama. Usually don't disappoint. So this was just, thank you so much. Then Dr. Mamudu, I want to encourage you. I know right now you are currently our keyboard king. Please, you have a very beautiful voice. We need to hear your voice, please.